typical celiac sprue damaged intestinal mucosa. So again, when you have a non-celiac gluten intolerance, your mucosal area looks absolutely normal, healthy. So what does it tell you? It's a functional problem. It's not a structural problem, it's a functional problem. So what do we see when we do blood work? What kind of blood test can make you think that you may be dealing with gluten intolerance? So first of all, it's malabsorption. So we have quite a few patients who come to us and say, well, you know, we have low level of vitamin D, or we have low level of iron, or we have low level of magnesium. These things do happen in patients with non-celiac gluten intolerance. So basically, we're talking about malabsorption of vitamins. Typically, we're talking about fat-soluble vitamins such as D, A, E, and K, and water-soluble vitamins B1 and B6. So malabsorption of microelements such as iron, calcium, magnesium is extremely common, especially iron. And malabsorption of microelements such as zinc and copper and selenium is extremely common. And when you have selenium malabsorption, you may end up with hypothyroid state because selenium controls thyroid function. So leaky gut syndrome is extremely common, and we'll talk about that tomorrow because we have a whole presentation on leaky gut syndrome tomorrow. Pernicious anemia, which is an autoimmune disease affecting our gastric mucosa and causing B12 deficiency. Osteoporosis and dysbacteriosis, which can present in diarrhea, bloating, and sometimes constipation. So when you have one of those symptoms and one of those findings, either through blood work or stool test, you need to become kind of aware that you may be dealing with gluten intolerance. And this is down to the point of our topic. So these are rheumatic diseases which are commonly associated with gluten intolerance. So we'll talk about Sjogren syndrome, fibromyalgia, pseudogout, osteoporosis, sacroiliitis, dermatomyositis, and psoriatic arthritis. These are the most common conditions which we see in our practice in conjunction with gluten intolerance. So let's talk about Sjogren syndrome. Sjogren syndrome is the most common autoimmune disease affecting women. So 10% of Caucasian women are affected by Sjogren syndrome. So it's an autoimmune disease mainly affecting glands producing fluid, such as lacrimal glands producing tears, salivary glands producing our saliva, as well as sweat glands producing sweat, and small glands within vagina producing vaginal lubricant fluid. So most of the patients who come to our clinic with Sjogren syndrome, they do have dryness, eye dryness, kind of very sensitive eyes, light sensitivity, kind of feeling like you have a sand in your eyes, dry mouths. So at the early stages, patients describe that they're thirsty all the time, they want to drink. So they complain that they have multiple dental problems, specifically cavities, and multiple infections, canker sores. They don't know what's going on, but in reality, it's a Sjogren syndrome. So Sjogren syndrome can affect also joints. It can cause skin ulcers. It can cause various skin rashes. We have quite a few patients with dry, annoying cough, and they go from one physician to another, and they're labeled typically with adult onset of asthma. It's a Sjogren syndrome. Sjogren syndrome affects our brain. It can cause fatigue. It can cause brain fog. And so if you have some of these symptoms, plus dryness is a must with Sjogren syndrome, so then you need to be tested for Sjogren's. And approximately 80% of Sjogren syndrome patients, they share HLA-DQ2 gene, and they do respond, some of them completely, some of them partially, to gluten-free diet. Fibromyalgia, probably most of you know what it is. It's a chronic pain, which is associated with debilitating fatigue, abnormal sleep, chronic insomnia, joint stiffness, problems with irritable bowel syndrome, as well as disturbances of the cognitive function. So there are specific criteria for fibromyalgia, and again, approximately half of the patients with fibromyalgia do get better when they start gluten-free diet. So osteoporosis, it's another very well-recognized condition in this community. So it's a condition when we have low bone density, and low bone density makes us prone to bone fractures. So it doesn't cause any symptoms, you don't feel it, but typically you can see, well, at a certain age you start losing your height. Sometimes appearance of your spine was kind of funky, it gets more rounded. And at the end, you start fracturing bones, hips, spine, shoulders. So gluten intolerance is directly linked to osteoporosis because gluten intolerance can cause vitamin D and calcium malabsorption, and it does decrease bone density. So on the other end of osteoporosis, there's another condition which is called Pseudogout, or calcium deposition disease. It's a condition when our body deposits calcium in the areas where it shouldn't be, and that extra calcium deposition results in very painful attacks, almost like gout attacks, but when you look under the microscope, the actual crystals, they're made of calcium. So why Pseudogout is linked to gluten intolerance? Well, again, the link is through vitamin D. So if we don't absorb vitamin D, our body requires to maintain calcium, so we need to get some extra calcium. How we can get it? Well, the body releases an extra amount of parathyroid hormone, PTH. That hormone releases calcium from the bones, and that calcium gets deposited in the joints. And during acute cyclic attacks, you're in pain. So there are quite a few other conditions which have some association with gluten intolerance. It's not 100%, but I would say between 20 to 50%. So these include scleroderma, rheumatoid arthritis, lupus, and juvenile rheumatoid arthritis. So all these patients, during initial workup, they need to be tested for gluten intolerance, because if they are, changing the diet can make huge difference in their life and in basically their condition. So briefly, we'll talk about non-rheumatic diseases which also have association with gluten. And again, the list can continue and continue and continue. These are just a brief, kind of eyebrow view of what do we see in our practice. So irritable bowel syndrome, IBS, we talk about that. Obviously, celiac disease and dermatitis herpetiformis. There's a big splash in community of autistic kids, and their parents, because apparently there's a large subset of patients with autism who do respond to gluten-free diet. So bipolar disorders, they have very strong link to gluten intolerance. Hyperparathyroidism due to vitamin D deficiency and eventually causing osteoporosis is a huge problem. Attention deficit. And there's a small subset of patients with so-called peripheral neuropathy. It's a condition where you have tingling and numbness in your hands and feet. And a subset of these patients do respond very nicely to gluten-free diet. There's another subset of patients with seizures or epilepsy. And these patients, to some degree, can also respond. Not all of them, but there's maybe between 10 to 20% will respond to gluten-free diet. Schizophrenia and chronic fatigue syndrome, again, we cannot claim and we cannot say that it's a 100% link, but I would say between 10 to 20% is a very reasonable estimation. So when we see patients in our clinic, how we can become suspicious that we're dealing with gluten intolerance. So these are typical presentations which kind of made us think about that we're dealing with one of those gluten intolerant patients. Thyroid disorders are extremely common, specifically Hashimoto disease of thyroid gland. Irritable bowel syndrome is extremely common. Iron deficiency, which is poorly controlled by oral iron, and it's obvious because if you have gluten intolerance, you don't absorb iron well. Osteoporosis, Sjogren syndrome, and asthma. And especially asthma in adults is associated with HLA-DQ8. There's a very strong connection between this particular gene and development of adult form of asthma. So on physical exam, what do we see? So there's a condition called keratosis pilaris when you have bumps around your shoulders right here, kind of goosebumps. So typically you develop this condition early during your childhood, and that condition persists and persists and persists. And once you see keratosis pilaris, it's almost 100% indicative of gluten intolerance. Second, it's kind of long scientific name. It's called periungual erythema. What it means that around your fingernails you have a red kind of ring. So it's a condition which is very strongly associated with gluten intolerance. And finally, dermatitis herpetiformis has a 100% association, and it presents with sometimes redness around your elbows, sometimes bumps and blisters around your elbows. So every time when we see one of those conditions in our clinic, the diagnosis is almost instant. And then sometimes, our suspicion kind of 50-50 with the blood work, and then what? So if we see that patients have low level of vitamin D1 or D3, our suspicion goes up. If we see elevation of parathyroid hormone levels, so our suspicion goes up as well. And then there are some exotic tests, for example, anti-neuronal antibodies, which we see in patients with peripheral neuropathy, SSA, SSB, these are antibodies which we see in patients with Sjogren syndrome, and so on and so on. A couple of things which I need to mention. Hyperprolactinemia, so elevation of prolactin is very common in celiac and non-celiac gluten intolerant patients, and this is a condition which can cause sometimes breast enlargement and more frequently headaches. So positive anti-TPO antibodies are frequently found in patients with Hashimoto disease, and then low levels of vitamin A, very, very common in patients with gluten intolerance. So finally, when it comes to the point that we need to make a diagnosis, what do we use? What kind of testing do we use? First of all, we heavily rely on genetics for an obvious reason, right? So we check for HLA, DQ2, and DQ8 complexes. So in addition, we're also utilizing blood and feces testing for antibodies, because in patients with positive antibodies, the chance of celiac disease goes up. Finally, if we're suspicious that we're dealing with not just non-celiac gluten intolerant, but celiac disease, we request intestinal colon biopsy. And then what? Let's say I have a patient who I think is very, very suspicious look very suspicious for gluten intolerance, but all the tests are negative. So what do we do in this situation? Then we ask our patients to go gluten-free for at least 3 months, and then challenge themselves. Go and try some gluten after that. And if symptoms are reproducible by the gluten challenge, by definition, this is a gluten intolerance. So although we're trying to rely on blood work, but again, obviously there are some exceptions. So what I want to say is that not all the patients with negative blood work are completely free of gluten intolerance. So that's not the case. So how do we approach for treatment of gluten intolerance? So basically there are 4 cornerstones. So obviously the first one is elimination of gluten. The second one, which is a must, we need to correct all the metabolic problems. And these metabolic problems include malabsorption, osteoporosis, and so on and so on. We need to correct immune responses, because obviously